Patients with vestibular disorders frequently report a specific and debilitating symptom, a profound sense of fullness or pressure localized deep within the head. Unlike the observable nystagmus of rotary vertigo or the physical mechanics of a fall, this pressure is a subjective sensation. It remains difficult to quantify through standard imaging, presenting a significant challenge for clinical measurement. While pressure can change with head position, many patients experience these sensations while upright, suggesting the cause involves more than the simple gravitational pooling of fluids. This sensation is an emergent property of the system, the result of multiple overlapping physiological failures across distinct anatomical regions. To understand its origins, we must map the physiological cascade, starting from the primary inner ear lesion and tracking its effects through the vascular, central nervous, and biomechanical systems. Addressing only the primary dizziness overlooks the interconnected physiological web that sustains the patient's cranial pressure. The process begins in the inner ear, specifically within the otolith organs, the utricle and saccule. These structures sense linear acceleration, providing the brain with precise data regarding the head's position relative to gravity. Beyond balance, the otoliths influence blood flow. The maculae send signals directly to autonomic control centers in the brainstem. When damaged, the data strength corrupts, sending erratic signals. Because these pathways govern cerebral blood vessels, this dysregulated vascular cycle contributes directly to the pressure. This otolith autonomic dysfunction explains how pressure sensations can persist even when a patient is upright, as autonomic-driven vascular changes become a dominant contributor to the sensation. Beyond vascular changes, altered dynamics in the cerebrospinal fluid, or CSF, provide an additional layer of internal pressure. The 2017 Kuhn study compared fluid velocities. This visualization shows normal, steady CSF flow on the left, contrasted with turbulent, irregular flow in Meniere's disease patients. Within the skull's rigid enclosure, this turbulent fluid creates an outward mechanical force against the structural boundaries. Vestibular head pressure is therefore a measurable dysregulation of intracranial fluid and vascular dynamics. While the inner ear initiates the signal, the higher processing centers of the central nervous system further amplify the sensation. The brain maintains spatial orientation by integrating three distinct data streams: the visual, the proprioceptive, and the vestibular. In this flowchart, these streams converge. If vestibular data becomes erratic, it conflicts with intact visual and proprioceptive inputs, creating sensory mismatch. Overwhelmed by conflict, the brain enters a state of cortical sensitization, spreading a high-alert error signal across surrounding regions. This sensitized state is a primary driver in the generation of headaches and the localized perception of cranial pressure. This mechanism also explains why vestibular symptoms and migraines co-occur with such high frequency. Both conditions share neuroinflammatory pathways. This illustration shows the intersection of the vestibular nuclei and trigeminal-vascular pathways within the brainstem. The relationship is reciprocal. Clinical evidence indicates that otolithic function is measurably lower during active migraine attacks. The brain's attempt to resolve conflicting data triggers an inflammatory cascade, translating sensory confusion into physical pressure. To complete the model, we must look at the gross biomechanics of the head, neck, and shoulders. Patients dealing with chronic dizziness often adopt a specific, rigid compensation mechanism, the complete reflexive immobilization of the head and neck to prevent further vertigo. Holding the neck and shoulders in a rigid isometric contraction for weeks at a time leads to chronic muscle exhaustion. This results in cervicogenic tension, specifically concentrated in the cervical spine and trapezius muscles. Tension in the upper cervical spine creates trigger points that refer pain upward into the skull, mimicking the sensation of deep intracranial pressure. This is frequently compounded by temporomandibular joint dysfunction, arising as patients clench their jaws in response to instability. Adding jaw muscles to our diagram reveals how TMJ tension layers additional facial and anterior head pressure over existing neck pain. Clinical anxiety regarding the dizziness often amplifies this muscle tension, creating a self-sustaining feedback loop. The physical instinct to guard against dizziness mechanically generates a profound secondary layer of referred pressure. Unifying these three axes reveals vestibular head pressure as a systemic failure with overlapping vascular, neurological, and musculoskeletal drivers. First, otolith autonomic dysregulation affecting vascular flow. Second, central sensory mismatch activating myelin pathways. Third, compensatory immobilization causing referred pain from the neck and jaw. When head pressure arises from this multifaceted web, a single modality approach often fails to address the underlying drivers, leaving the patient with persistent symptoms despite successful treatment of the primary vertigo. Effective care requires diagnostic evaluation that concurrently assesses vestibular function, neurological state, and musculoskeletal health. Treatment should combine targeted vestibular rehabilitation to address sensory mismatch with neurological migraine management. This foundation must be supported by cervical and TMJ physical therapy alongside stress management to break the muscular feedback loop. By addressing the entire interconnected web, clinicians can move beyond the primary dizziness and finally alleviate the burden of vestibular head pressure.